Shall we? Okay. Good morning, everybody. Welcome to Ground Rounds. I would like to thank Retu, Bill, and everybody that is involved in Cardiopregnancy program for letting me be part of it. It's a true privilege. We'll start the Ground Rounds with the case presentation, and I will present a case of a 29-week pregnant patient that presented to us with severe aortic insufficiency secondary to acute bacterial endocarditis. This is a case of a 36-year-old female that is 29 weeks pregnant, has a history of miscarriage, that on April 29, 2019 underwent routine dental work. Following then, she experienced some fevers and chills, and a week later she was admitted to the hospital with signs of systemic infection. Blood cultures drawn at that time grew Gemella species and stayed positive for 3 consecutive days. She was placed on appropriate antibiotics, ampicillin and gentamicin. ID was consulted, diastolic murmur was identified, and she was transferred to Heart Hospital with the suspicion of infective endocarditis. On arrival, echo was obtained that showed severe aortic insufficiency and dilated ascending aorta to 4.2 centimeters. EF at that time was normal, and she was hemodynamically stable. However, her heart rate was in low 100s up to 120, and even though she was not really experiencing any shortness of breath and she was on room air, her BNP was elevated over 600. The TEE that was obtained the following day, as we can see, showed non-coapting aortic valve cusps with pretty high burden of bacterial vegetations on the ventricular and aortic side. We see there is no coaptation between the cusps. Sinotubular junction is somewhat effaced, and the ascending aorta is dilated. On Doppler study, she had torrential AI and some MR that later on the intraoperative echo was found to be moderately severe with some restriction of the posterior mitral leaflet, most likely secondary to the left ventricular strain and dilation of the mitral valve annulus. Ad hoc meeting was called in our ICU. The participants of the meeting were OBGYN, neonatology, 2 cardiologists taking care of the patient, cardiac surgery, and ICU. Going through all risks, benefits, and potential scenarios where this case can go, we decided to proceed with emergency cesarean section, followed by aortic valve or aortic root surgery, depending on the level of destruction on acute bacterial endocarditis base. The decision was made. She went to the operating room the same day, a few hours later in the evening. The decision was made to obtain awake percutaneous access. We inserted micro access through the right common femoral vein and left common femoral artery. This was done with ultrasonic guidance and micropuncture technique. This was performed by one of our interventional cardiologists. We did it in order to have readily available veno-arterial access in case of cardiovascular collapse on induction of anesthesia. And even though aortic insufficiency was present, we had ECMO readily available as a backup. The reason this case was taken to the operating room right away was multifactorial. So first, we, after discussion with neonatology and OBGYN, the pregnancy was thought to be mature enough to be safely delivered. And from cardiovascular perspective, a patient that presents with acute, severe, or torrential AI really doesn't have any temporary mechanical circulatory support options, because severe aortic insufficiency is a contraindication for ECMO. I put relative here in parentheses because I believe that a patient that has cardiovascular collapse and suffer cardiac arrest can be placed on ECMO regardless. But we know what happens next. Patient is immediately put into severe pulmonary edema because of elevation of LVEDP and pulmonary venous hypertension because the pressure gets transferred from the aorta immediately to left ventricle and left atrium. Patient was underwent primary cesarean section. Induction was uneventful. She remained hemodynamically stable. This was done through low transverse incision, and uterus was closed with a single layer. The abdomen was kept open and packed with laparotomy sponges in order to prevent any blood accumulation during cardiac part of the procedure, because patient is systemically heparinized to ACT levels of 500-600 in order to place patient on cardiopulmonary bypass. So it's a full anticoagulation. The cardiac operation immediately followed. Patient was re-prepped and re-draped. The procedure was done through median sternotomy with central cannulation. Upon exposure of aortic valve and aortic root, we found completely destroyed aortic valve cusps, as we expected, and vegetations were present all over in the aortic root, around coronary ostia, in the LVOT. The anterior mitral leaflet seemed clear. We found two aortic root abscesses. One was penetrating from the right coronary sinus towards main pulmonary artery, and the second one was going basically through and through aoromitral curtain over the roof of the left atrium. So this was pretty destructive aortic root endocarditis. And as mentioned before, intraoperative echo showed moderately severe mitral regurgitation with non-coapting mitral leaflets. This is a cartoon of heart skeleton. We always, people that work with aortic root, we like to say that aortic root is hugged by other parts of the heart, and that's truly what it is. We can see that any infection happening in the aortic root can go in basically to any other valve and any other chamber of the heart. The two abscesses that I marked here, one was going towards the PA. This abscess is fairly dangerous because it can affect the left main coronary artery if it's when it spreads between the PA and the aorta. And the other one here penetrated through the aoromitral curtain that lives between the left and right trigone and was going over the roof of the left atrium. The roof of the left atrium here is removed. This is the tricuspid valve and right atrium. So in case of bacterial endocarditis, the goal of any procedure is to completely resect and remove any infected and necrotic tissue. And the reconstruction of the valve, usually biological repair is preferred. However, there's no strong data for it. Patient underwent mitral valve repair with semi-rigid complete Memo 4D ring. This was done in order to correct the functional MR that she suffered secondary to her LV strain. And aortic root was replaced as a whole with 21 millimeter cryopreserved aortic allograft or homograft. Coronary implantation preceded the root attachment. And as mentioned here, we kept the coronary ostia, meaning aortic tissue around the coronary ostia, relatively big because at her age, she's most likely looking at reoperation in the future for homograft degeneration. This is a typical picture of the homograft. Our homografts in our cryobank that we have in the core on the third floor usually have the whole arch preserved, so we actually can do not only roots but also more complex reconstructions that we've done here before. And this is the aortic root replaced as a whole with coronary reattachments. In terms of guidelines telling us who should be taking care of patients with aortic valve endocarditis, this is a revision of the AATS guidelines from 2016 under leadership of Dr. Gasta Patterson from Cleveland and Joe Caselli from Texas. So two very experienced aortic root surgeons. So they agree that patients should be cared for at centers that can provide interdisciplinary care and operated by surgeons that are pretty facile with all sorts of reconstructive procedures for the aortic root. As mentioned before, different structures can be involved. Prosthesis choice is not there is no clear consensus. However, as mentioned here, in case of invasive and destructive native aortic valve infectious endocarditis requiring root reconstruction and replacement, using allograft may be beneficial. And basically, what the common practice and common practice among cardiovascular programs is that it is evaluated intraoperatively. The level of destructions dictate the choice of prosthesis and also the comfort level of working with cryopreserved tissues and root replacements. I brought up this study. This is a study from 2 years ago from Brigham and MGH. This is another kind of attempt trying to show a benefit of a homograft over traditional mechanical or tissue prosthesis for aortic valve endocarditis. And this is the prospective review of over 300 patients where the homograft patients were compared against traditional bio and mechanical prosthesis replacement. And this study, again, didn't show a reinfection rate benefit or survival benefit. However, again, typical for those reviews, the authors conclude that the final decision is made intraoperatively, and that's why they stress the level of experience is a key component in their opinion for successful infective endocarditis treatment. This is a completion echo from the OR. We can see the mitral ring. This is the root replaced with the homograft, aortic valve cusps coapting pretty well. There is no AI, trace MR, and gradient through mitral valve at that time was 4, and gradient through the aortic valve and LVOT was 7. That remained stable on the follow-up echo. Follow-up CTA showed pretty well-positioned root. As we can see, there's no residual ascending aortic aneurysm, as this was replaced by the ascending aorta of the homograft. LVOT is wide and open. This is the left main coronary artery. I can guarantee that the aortic tissue left in place is about from here to here. So that's left for the future reoperation. This is the RCA, and patient will be followed with serial echoes and probably is looking at some reoperation at about 10 to 15 years mark, most likely with mechanical Bental, as she will most likely degenerate the homograft. Thank you so much, and we will proceed with the next presentation. I think they will.
It's up there for a minute.
Yeah.
There. Oh.
I'm gonna try one thing. Sorry.
It's okay. Does it look like a
Wow.
slide?
That looks like.
Okay.
Here's.
How do I
And then
advance? Just advance there?
Yeah.
Okay.
Yeah.
All right. So, good morning. Wow. It filled out. Can you guys hear me okay? All right. So, I just got back from Mexico. So, if I seem kind of sleepy, it may be because I just got back from Mexico. Mexico was lovely. There was no ice. The sun was shining. The beach was sandy. The skies were blue. Do you feel bad for me? So I'm going to talk about pregnancy and heart disease because that's what we're here to talk about. And I thought Dr. Mudy's case illustrated a couple of key points that hopefully we'll touch back on, one being primarily multidisciplinary. So I spent the last year talking to a lot of people about pregnancy and heart disease, and I come back to the why and what our role is and why a cardiologist. And really what I'd like people to sit and think about is heart disease before pregnancy, heart disease during pregnancy, and then absolutely heart disease after pregnancy. And why is that? When you look at the United States, our maternal mortality rates are just woeful. I have no other word for it other than woeful. We have a death rate of 26.4 per 100,000 live births. to give you an idea, to put it in perspective, compared to other countries in the world that are developed, Sweden, it's 4.4 per 100,000. The United Kingdom, 9.2 per 100,000. And Canada is 7.3 per 100,000. In the last 3 decades across the world, there was a reduction in maternal mortality rates by 44%. In developed country, that reduction was about 48%. But in the United States, in the last 1.5, 2 decades, our maternal mortality rates rose by 27%. Okay, so you say 26.4, that's not very much. But when you think of each of those deaths, about 84 women suffered a severe morbid complication for each death that we recorded. So again, we are a dangerous place to have a baby. And what is the #1 cause of maternal mortality? Turns out it's cardiovascular disease. When you look at all the studies, there was a 9-study mortality review that just got published in 2018. Our last set of data is from 2016. It turns out the #1 cause, now I'm told this is the pointer, is that right? No? Oh, well now I've gone backwards. How do I point, or do I just point?
Let's see if we can use the.
I'll just point. So I'll use my finger. So if you look here, this blue is cardiovascular conditions. And that's divided up into congenital heart disease, Dr. Hahn and her colleagues, ischemic heart disease, valvular disease, hypertensive heart disease, and congestive heart failure. It is the #1 cause of maternal mortality in this country. Followed by pulmonary embolism, which is in the, I don't have a pointer, in the green at about 9.2. Hemorrhage, which is in the 11%, and then infection, which again, I would argue our patient was both infection and cardiovascular, which is at 13.3. And then other non-cardiovascular things such as renal failure. Ooh, do you have a pointer?
I always go.
That's amazing. Does it work? Other non-cardiac conditions makes up the remainder.
Yes.
And when we look at maternal mortality, there's a huge disparity. Oh, it's not working on the screen though. No. There's a huge disparity by ethnic group. It turns out that if you're an African American woman who's pregnant in this country, you're 3 times more likely to die than a Caucasian woman in this country. If you happen to be American Indian or an Alaskan Native, you're 2 times more likely to die than as a Caucasian woman in this country. Interestingly, the rates of death in American Indian and Alaskan Natives have actually started to go down. The rates of death in African American women haven't budged, and they continue to go up. There's a lot of reasons for this disparity, more than I can go into in about 15 minutes. Part of it is related, again, to the cardiovascular disease risk factor that these women have, including obesity and hypertension. We all know African American women are at higher risk of heart failure and stroke. Those same risk factors put them at increased risk of dying through pregnancy. But then again, there's issues with disparity in care and access to appropriate management. When do these women die? 38% die while pregnant, 45% die within 42 days. The World Health Organization actually looks at maternal mortality within the first 42 days after delivery. So that's the definition of maternal mortality. But about 18% of these women do die within that first year after delivery. And if you look at the causes, that 18% is primarily heart failure and arrhythmogenic death. So again, cardiovascular. And what's sad is about 60%, 60 to 70% of these deaths at any time are preventable. And so we're not doing well. Actually, Minnesota is, if you look at the states and how they're ranked, we're not in the lowest quartile, we're in the second quartile, but we're at least not in the highest quartile for our maternal mortality rates. So why a cardiologist hanging out with OBGYNs, actually maternal fetal medicine doctors? I think it's really important that cardiology has a strong role here. It's important for us to recognize these patients when they present to us from the time of first care. I think it's really important to differentiate pathologic cardiovascular signs and symptoms from physiologic cardiovascular changes, which I'll go through in a minute. And it's important for us to not only have a role with these patients antepartum, but postpartum, because these individuals end up having cardiovascular disease risks later in life. So if you think about the antepartum, the prepartum, We know that women with heart disease should see a cardiologist prior to pregnancy. I'm not going to talk a lot about congenital heart disease because Dr. Wagner is, and Kelly will later this year as well. But what we know is that these women should get preconception planning. And if you look at congenital heart women, less than 1% of them actually do get preconception planning. But women who have acquired heart disease, who are now older as our maternal age has risen, should also get preconception planning. We know that there are risk factors that affect pregnancy quite strongly, one being chronic hypertension, the other being dyslipidemia, the other being obesity. In fact, if you look at 5 characteristics, your BMI, systolic blood pressure, diastolic blood pressure, HDL, and triglycerides, you can account for about 40% of the difference in some of the postpartum cardiovascular risk factors, just based on those 5 prepartum things. So these individuals, these women, one, they don't have the awareness to know that they're at higher risk for things like preeclampsia, gestational hypertension, and gestational diabetes, which then again puts them at increased risk of having maternal mortality. But 2, they're at higher risk for having cardiovascular disease later in life after they deliver. So pregnancy is the quintessential stress test. Who of you all know about what the race across America is? Has anybody heard about the race across the United States? Oh, there, Steve. I knew you would have. Thank you, Steve. So there was this really lovely article that was published looking at the metabolic threshold limits that a human body can hit during high-intensity aerobic activity, such as running a marathon, and long-distance running, one being the race across America, which from what I understand is a race truly across the United States. It's over 140 days. The metabolic threshold for a human being who does that caps out at about 2.5 times baseline metabolic threshold. Pregnancy caps out at about 2.5 times the metabolic threshold of your baseline, except it's 280 days. So it's like running across the United States twice. That's what pregnancy is like. Our heart rates go up, our stroke volume goes up, our cardiac output goes up. Our systolic blood pressure does go down until you get to about the 3rd trimester, and then it starts to rise again. And as you go to labor and delivery, you have huge fluctuations of vascular tone, blood pressure, and cardiac output, stroke volume, and heart rate. So this is a stress test. Well, what do you have with stress test? You have symptoms. You have chest pain, shortness of breath, palpitations, feeling tired, all sorts of things that we account to pregnancy. This is from the ACOG practice bulletin that came out in May of 2019. I now read OB literature on top of cardiology literature. I found that kind of fascinating. But they did a really nice job at trying to differentiate who we as cardiologists and, again, primary care providers should worry about and who we should not. So the whole, your heart rate's fast, it's just pregnancy, should be a diagnosis of exclusion, not let's blame pregnancy first and then look at the heart later. Sometimes it is just pregnancy, but those symptoms are often mild and self-limiting, often not associated with physical findings. But as you start developing physical findings and more moderate to severe symptoms, these individuals probably need further evaluation to be taken seriously. And so they came up with a really nice algorithm of symptoms, vital signs, risk factors, and physical exam findings. And if you have one of each category and a history of heart disease, or you happen to be African American, or you happen to have obesity, issues with hypertension, diabetes, those all put you at increased risks. And those individuals probably are best suited by being evaluated by a cardio-obstetrics program, or at least high-risk OB. If you have minimal findings, a lot of times these things can be evaluated and then just reassurance and routine follow-up is recommended. I would say the 3 baseline things that individuals, if they show up in clinic, should get: an EKG, a BNP, and an echocardiogram. If those things are normal, more likely the symptoms are due to pregnancy. These individuals can be reassured and just followed up appropriately. So if you take a look at this algorithm, and this algorithm actually comes from the California Maternal Quality Care Collaborative Cardiovascular Disease Task Force. So California is one of 3 states that have actually reduced their maternal mortality rates by using toolbox kits such as this in their hospitals. It turns out that if you take this algorithm and plug in individuals who ended up having high maternal morbidity and mortality, 88% of them would have been appropriately identified and would have been a spot where we could have prevented a death or a near miss. So again, this kind of algorithm applied on a regular basis actually would help save mothers' lives. If you don't take anything else home other than the whole women die in this country, I would take that home. I have two other key pearls that you should take home. Peripartum cardiomyopathy, this is something Dr. Wagner and I wrestle with every time we have clinic. This definition is thrown out quite a bit. I put this up here because the definition is distinct and strict. It is an EF of less than 45%. If you don't have an EF of less than 45% without any other reason for the reduction in your EF, you do not have a diagnosis of peripartum cardiomyopathy. Why is that important? Because of subsequent pregnancies. We know that women with peripartum cardiomyopathy have huge morbidity and mortality later in life. There's, again, a really nice algorithm here that shows how to make the definition. But keep in mind, women with pregnancy do present with heart failure, even if their EFs are not reduced. More often than not, it's secondary to preeclampsia or severe gestational hypertension. The other part that mimics heart failure would be pulmonary embolism. But a lot of times women come in with acute diastolic heart failure secondary to their hypertensive state and the volume overload state of pregnancy, and they leave with a diagnosis of peripartum cardiomyopathy, which is not the case. They probably have had severe gestational hypertension or preeclampsia leading to strain on the LV. So I think it's really important to define peripartum cardiomyopathy. I'm not going to talk about congenital heart disease because Dr. Wagner will, but again, the one point being 23% of women who have congenital heart disease get no antenatal care, none whatsoever, let alone preconception planning. So we got to get better at taking care of these women. PAMI, pregnancy-associated myocardial infarction, also increasing as the age of our mothers increase. They have more cardiovascular risk factors, and we're seeing a lot more women present both with STEMI and non-STEMI. Troponins should never be abnormal in pregnancy. If you take nothing else home, take that home. If you have an abnormal troponin and you're pregnant, something is wrong. More often than not, these women have atherosclerotic disease. But again, we're seeing a rise in things like coronary artery dissection, coronary thrombosis, vasospasm, and yes, stress-induced cardiomyopathy. Apparently being pregnant is stressful. And all of those things that impact us through pregnancy come back and hit us in the future. So there's a lot of research now that shows things that occur in pregnancy, which is, again, a stress test for women, come back and impact us later in life. Preeclampsia is kind of the pathognomonic disease process that started all of this research. We know that women with preeclampsia have increased cardiovascular disease and increased mortality later in life. We used to believe this was like 15, 20 years after you delivered your baby. 15, 20 years later, you'd end up with having increased risk of cardiovascular disease. This, again, is from California, and it's a very busy slide, and I don't have a pointer. But what this is looking at the first 5 years after delivery. This is about 1.5 million live births. And this is peripartum cardiomyopathy. This is the hypertensive disorders, and then this dark square is preterm birth. And what you can see is within 5 years after delivery, these women are at increased risk of myocardial infarction, heart failure, as one would expect, stroke. And it doesn't matter whether you've had peripartum cardiomyopathy or preeclampsia superimposed on chronic hypertension. It increases your risk. So again, the role for cardiology here is taking care of these women after they deliver to ensure that their risk is reduced. So I like to think of pregnancy, again, stress test for us later in life, and looking at things prepartum, the risks that we have going into pregnancy put us at increased risk of both maternal mortality and adverse pregnancy outcome, primarily due to placental dysfunction, cardiovascular maladaptation, and physiologic glucose issues. Those things that then happen to us in pregnancy, coupled with our pre-existing risk, endothelial dysfunction, and our lifestyle choices, lead to bad outcomes later in life. So again, what happens to us pre-pregnancy, intra-pregnancy comes back and gets us later in life. When you think about cardiopregnancy programs, and Dr. Wagner will go through the incarnation and the development of a cardiopregnancy program, we look at each woman by risk score, and there are 4 out there. right now, the modified WHO classification from the World Health Organization, the CARPREG score, which is now CARPREG 2, which was just published in 2018, and then the Zahara score, which is congenital heart disease specific. Two large trials, ROPAC, which is in its third version looking at aortopathies and aortic valve disease right now. The first two have been published. And then we will be a site this year for the HOPE registry, which is the United States Congenital and Acquired Heart Outcomes in Pregnancy, looking at how to manage these women in the United States. So we will be a site in the fall as they kick off, which I'm very excited about. So the maternal WHO classification, WHO 1, WHO 2, very small increased risk in morbidity and mortality, all the way to WHO 4, where there's actual recommendation for perhaps termination if pregnancy continues. And then expert counseling and close following. These are the different diagnoses, and again, our patient would have been an MWHO class 4. She would have been high risk. What does that mean? In the world at large, her risk of dying or having a morbid event is about 50%. In advanced countries, so developed countries, it's a little bit tempered, and that risk is about 40%, but very, very high risk of having a bad maternal outcome. Maternal outcomes, as you know, translate to bad fetal outcomes. So as the CARPREG group, which is the Canadian scoring group, came up and revised their data, they actually looked at how our risk scores do compared to what actually happens. And it turns out that other than the advanced countries' maternal WHO classification, the scores either under or overestimate based on their score. So they revised their score, and there are 10 things that they looked at, and their revision score is actually done really well, but those 10 things are divided up by patient history, physical exam, specific lesions, imaging, and delivery of care. And we know that individuals who've had cardiac events prior to pregnancy are high risk. The baseline New York Heart Association class 3 or 4 puts us at high risk, and having a cardiac issue and no prior cardiac interventions, of course, puts us at high risk. On the physical exam findings, cyanosis. No woman should be pregnant and have an O2 saturation of less than 90%. Mechanical valves, of course, put us at high risk. Coronary artery disease, and then anybody with aortopathy. Anybody with a reduced ejection fraction, regardless of the cause, is at higher risk. Obstructive and high-risk left-sided lesion, more important than right-sided lesions. And then, of course, pulmonary hypertension. When you look at the ROPAC data, pulmonary hypertension is actually the biggest impact of morbidity and mortality around the world. And then, of course, anybody who has late first antenatal visits. A few other things that put us at high risk, the rare, not studied diagnoses, SCAD being the big one there. We don't know enough about it and who recurs and how it recurs during pregnancy. So those individuals should be watched very carefully. Anybody on anticoagulation, Coumadin, of course, any other high-risk findings, and then advanced maternal age, hypertension, and obesity. Those things increase risk. So what can we as cardiologists do? I think the big thing is recognize and manage cardiovascular disease risk factors preterm. Preconception evaluation. I can't emphasize this enough. I think it's really important for groups like Dr. Wagner's, the MFM groups, to be involved prior to the decision to get pregnant, because if pregnancy is not contraindicated, these individuals need close follow-up and appropriate delivery plan with multidisciplinary communication. If our OB colleagues say the baby should and can come out, the baby should and can come out so we can take care of the heart. Cardiovascular follow-up during pregnancy and postpartum. Early postpartum cardiovascular assessment in the first 1 to 2 weeks post-delivery. So it used to be that women would be seen postpartum at 6 weeks. These women die 30 to 40 days after they deliver. I can tell you stories about patients we've actually been taking care of who show up to the ER and get sent home with bronchitis because they show up short of breath because they are no longer pregnant. A week later, they're still physiologically pregnant. So again, if you don't leave with anything else other than the maternal mortality rate, if you see these women back in clinic or you get called to the ER and they're short of breath a week after they deliver, it's probably not bronchitis. High-risk cardiovascular disease should have long-term cardiovascular care. And then what I've spent the last year doing, and probably will spend the rest of this year doing, raising awareness of the elevated maternal mortality and morbidity risk predominantly due to cardiovascular disease, in terms of talking to OBs, primary care providers, and getting the word out. I think the more women are aware of their maternal mortality risk, the better we all do. And so again, as this entity becomes more concrete, cardio-obstetrics leads to a cardiopregnancy team. And I can't voice enough what Dr. Mudy said. It's the multidisciplinary communication of cardiologists, critical care, Dr. Kirkland's here, and then maternal fetal medicine. So we have a great team. We have Dr. Lesser, Dr. Hahn, Dr. Gornick, Dr. Moore, the great maternal fetal medicine, our anesthesiologists, our critical care team. We meet every Tuesday, second Tuesday of every month to discuss these patients, so they have multidisciplinary delivery planning and multidisciplinary follow-up. So, and with that, I'm going to turn it over, see if I can turn it over to Dr. Wagner. See if this works. And there's no highlighter. There you go.
And what advances it, this?
Oh no, the arrow.
Oh, the arrow, okay. Well, I, like Retu, returned this weekend from Jamaica, so I'm still trying to dry out. Was it raining there? Can everybody hear me? Just as a little follow-up to Carol's case presentation, the most difficult piece of that particular discussion, as Carol and I were intimately involved on an acute basis, this was an IVF pregnancy in a patient who'd had 15 years of infertility with a singleton pregnancy, who shows up acutely ill, hemodynamically unstable. And after Des had gone over the particular issues with her and called me and said, you need to get over here. And so the first two people she meets is Carol and I, who say, you know what? We need to sit down here because we have a major issue. So in deference to Carol and in deference to Des and all of the team that were involved in the care of this patient, I will tell you that the counseling, if you will, of risk and need for intervention was, if you will, probably the most difficult piece of the entire process here. And Carol and I obviously took a tremendous amount of time in going over, if you will, what needed to be done, what were the risks of not doing it, and the issues related to a 29-week pregnancy. As follow-up, that baby spent about 6 weeks in the NICU, did absolutely phenomenally, had no, if you will, neonatal complications from relative extreme prematurity, and is in fact home. So all in all, a good outcome, if you will, for both mom and baby. You know, as I look at things in terms of pregnancy, it always starts with conception, and then embryogenesis, and then organ development, and then a 39 to 40 week worth of multidisciplinary care, delivery, and the first 6 weeks to 8 weeks post-delivery. So in fact, as I look at the Cardiopregnancy program, I look at the embryogenesis that was, if you will, founded upon conception, of which Kelly and I, not euphemistically, suggested about 3 years ago. We need to have a program because obviously the news that clearly is in the forefront is that there are more adults with congenital heart disease than there are children. It is the success, if you will, of our congenital cardiology and cardiovascular and adult congenital heart disease, if you will, programs. That obviously it's a complete reversal from where it was in the 80s and 90s when Kelly trained. So the concept is that patients that we now see and we counsel, that when I was training in the 80s and 90s, in fact, they were all counseled for termination, all. because the risk to mom was clearly greater than the likelihood of an optimal outcome. So obviously this program has come about over the last 3 years based upon the dedication from Kelly, from Retu, from the foundation, from all the people who have, if you will, been a part of this program, including Lisa through our, if you will, OB critical care program, to put this program in the forefront, if you will, at Abbott Northwestern. So the Cardiopregnancy program, as you may or may not be aware, involves Children's Heart, Abbott, Minnesota Perinatal Physicians, Midwest Adult Congenital Cardiac Center, and the Department of Critical Care Medicine here at Abbott Northwestern. It's not a small group of people and involves, obviously, a tremendous multidisciplinary approach. So each of the three, if you will, Venn diagrams here demonstrates a partnership that continues, if you will, to grow. And although we thought early on it would be a small number of people, it exploded exponentially. The first year, basically, the program was Kelly and I, and we saw all these patients together. And the first year or so in the last 3 years, there were probably anywhere from 5 to 10 to 15 patients. At last count, we now, over the last 3 years, have followed over 120 patients who either have acquired or congenital heart disease, and the program continues to expand. So it's not a small part of what we do on a daily basis. So why did we decide to do this? We decided to do this because we needed a program to provide a multidisciplinary model, which included both outpatient and seamless inpatient quality of care to obviously patients who previously were never given the opportunity to consider pregnancy. This has been the major focus of the program. As Kelly and Charlie and all of the individuals who have been a major focus through the adult congenital heart disease program here. Congenital heart disease and its management is a medical success story. You can clearly see that the number of individuals who are adults clearly outweigh children, which is an absolute reversal, as I said, from where it was in the 70s and 80s. Contemplating pregnancy is not a small decision. As Retu has gone over, it's a stress test. It probably unmasks more cardiovascular disease than people have been well aware of. And one of the things that, having not been born and raised in the Midwest, having been born and raised in New York City, which is clearly a melting pot, not everybody's blonde-haired, blue-eyed Scandinavian. One of the things, obviously, that has become at the forefront of almost everybody, if you will, within our particular arena here in Minneapolis and St. Paul, is the number of patients who have undiagnosed congenital heart disease. They show up in the ER with shortness of breath. And everybody knows, if you have gone through your ER rotation, as many of us did years ago, there is a mantra in the emergency department. Treat them and treat them. So these patients show up, early pregnancy, with all the typical, if you will, signs and symptoms that may be attributable to the adaptive changes of pregnancy. And they go home, they come back another couple of days, same symptoms, go home, And they come back again another couple of days, and the astute individual finally says, well, I think maybe we need to do a little bit more investigation. And obviously then, all the appropriate testing which is done demonstrates a patient who has unrecognized and undiagnosed either congenital or acquired heart disease. We live in a melting pot here now. And so obviously, a major part of this program is to educate individuals that clearly the adaptive changes in pregnancy need, if you will, to be a diagnosis of exclusion as opposed to the issue related to cardiovascular disease. It's similar, if you will, to the sequential, if you will, analysis of congenital heart disease. Appropriate, if you will, structural makeup of the heart should not be presumed. It needs to be diagnosed. So, pregnancy and reproductive care is essential. It is the mainstay, if you will, of the program. I think clearly, if you will, we can see there is a clear relationship, if you will, to the relationship to adult congenital heart disease specific programs and mortality. Despite, if you will, the politics and geography, adult congenital heart disease and its management is a specialty not to be dabbled in. It is a clear, defined, and definitive specialty, which affords this patient profile the best quality of care. So our program currently serves as the continuum of patient care needs. Contraceptive planning and care is essential for these patients. Some patients, yes, we do need to sit down. And if you will, as I have had occasionally with my teenage daughters growing up, now empty nesters, you know, what part of no don't you understand here? This is not a dialogue. Or the other is, are you crazy? So, in fact, it is a major part of what our cardiopregnancy program entails. Pre-pregnancy consultations with patients who are interested in becoming pregnant. That, if you leave with nothing else from here, the most important discussion about the potential issue for pregnancy needs to occur before they ever get that way. And we're not just talking about the 25 or 29 or 31-year young individual. We're talking about individuals whom nobody thinks, well, you know, they're young. They're 16, 17, 18. They're 20. Trust me, we all know things happen. And particularly in patients who have clear known congenital heart or acquired heart disease, they need to be counseled from the time they have the capability of getting that way, despite, if you will, shall we say, the concern about, I don't really want to talk to them about that. They need to be talked to about it. And if you will, the families need to be talked about it. Because showing up at 18 weeks with significant acquired or congenital heart disease is not, if you will, the ideal time to sit down and go over what are my risks of this particular issue. So it is absolutely tantamount to the cardiopregnancy program. All of our cardiopregnancy patients receive outpatient care, either on a consult or primary basis. If the patient does not require, if you will, all of the needs of our cardiopregnancy program, in fact, we put down the recommendations based upon necessarily their surveillance, their care, and whether they can deliver within their regional center or not. If there's a change in the care plan, obviously, we make that clearly known, if you will, going forward in seeing them. Pregnant patients who need inpatient care, obviously at any point during their pregnancy, may be admitted, if you will, to our Mother-Baby Center, Minneapolis, or MHI, depending upon obviously their condition, if you will, and the care plan, which will have already been established, as you know, from our multidisciplinary care program, of which we meet not only, if you will, the second Tuesday of every month, but all of us, if you will, get together on a daily or weekly basis as needed to manage, if you will, this complex profile of patients. Again, our Cardiopregnancy Multidisciplinary Conference meets the second Tuesday of each month. It's a roundtable discussion of all the cardiopregnancy patients. We establish, if you will, a consensus, if you will, with everybody's input. The entire cardiopregnancy team attends each of the meetings, which includes all of the multidisciplines that are required. And again, probably the most important piece of this is our imaging, if you will, and our, shall we say, our imagers and our ultrasonographers and our CT MRI. This simply underscores the need for patients who clearly have underlying congenital and or acquired heart disease need to be seen by those who are clearly comfortable in the management, if you will, of this profile of patient. It is not, if you will, typical internal medicine. It's not just typical general cardiology, because the hemodynamics of these patients are clearly different. And they are different than when they were children. Adult congenital heart disease is not just a manifestation, if you will, of childhood congenital heart disease, because obviously the structural dynamics change as the individual ages and as the cardiac morphology ages. So they aren't just little kids anymore. They are adults with clear congenital heart disease, and the plumbing and the dynamics may have significant change throughout their course. Obviously, I'm not going to spend a lot of time, if you will. Retu's gone over the particular issues in terms of where the risk factors, if you will, are for potential complications of heart failure in pregnancy. And again, the risk factors for heart failure, this is the ROPAC data. We're now again into ROPAC 3, which we are clearly, if you will, intimately involved now in the ROPAC data collection system. And again, congenital heart disease, looking at issues related to risks as well as specific lesion. Maternal predictors, if you will, of neonatal events. Obviously, the one underlying issue that everybody needs to remember is adult congenital heart disease, issues related to the genetics and the risk factors for congenital heart disease, which there clearly involves, if you will, our pediatric and our fetal cardiology team because of the risk factors of genetic transmission. And again, these are simply the specific predictors of adverse neonatal and maternal outcomes, clearly almost all related to gestational age and the particular profile. Again, I'll skip over these. The CARPREG scoring, she's already gone over, and the risks. And again, just as a thank you for the opportunity that not only you all, but I know that the foundation has given us a tremendous amount of support, of which I continue, if you will, my support to the foundation, if you will, for this continued interest, because without everybody in this room, this program would not, if you will, be able to go forward. And actually, the privilege of which we are given is the patients that we are allowed to participate with. So thank you.
It's not so much a question as the opportunity to brag about this program and the OB critical care program, but all the patients, pregnant or postpartum patients who it came to the ICU anyway, none of them died. We had 100% survival, which is pretty impressive given the statistics you quoted for the country. A lot of that is you guys.
And you.
And you, Lisa.
And you, Lisa.
Yes.
I mean, Lisa's been a huge, for those of you who don't
Yes.
know Lisa, she's been just a huge supporter of when her colleagues, will remain nameless, come back and say, this person doesn't need to be in the ICU, and I say, yeah, no, they do. I just call up Lisa, and Lisa says, no, yeah, they do. So I will say Lisa's been a great, great support and resource, so.
And Josh certainly has too, and Dave.
Yeah, Dave Williams,
Yeah, absolutely.
So it's a great global effort. Thank you. What do you two or three think we need to do next? What do you need from us that will move this forward the most?
I think from a cardiology standpoint, it goes back to, well, if you see somebody who's pregnant, now not necessarily since you come to the cardiopregnancy meetings and everything, but if you see somebody who's pregnant, I think the number one thing is don't assume it's pregnancy. Pregnancy is the diagnosis of exclusion. If they're having symptoms and they're any more than mild, take it seriously, do the EKG, get an echo, get a BNP. That's really what we do when we get symptomatic patients. And again, it may all be due to pregnancy. Women have different heart rates. Some women we see, and it truly is, their heart rate's sinus tachycardia at 130 and they're just set there. But prove that it's not something else, much like the congenital heart disease. And I think
But as a system,
As a system.
yeah, I'm sorry, as our system, what can we do to make this work better and be better for the patients we have?
there's a lot, that's a lot of.
Well, I think, John, it really goes to, I think the three-legged stool, to be honest with you. The two biggest barriers we have to this program, as well as our OB critical care program, is resources and the need, obviously, if you will, to have a data collection and a data system which allows us to look at, yes, I'm interested in what Cleveland Clinic is doing. I'm interested in what Mayo is doing. But I'm much more interested in what is our cardiopregnancy program? What do we do for these patients? How we do for these patients? And what is our outcome? Because at some point in time, I think all of us, not necessarily to stand on a pedestal, but at some point in time, I'd like people to look at Abbott Northwestern's cardiopregnancy program as being one of the premier, if you will, programs in the country of which these patients have the opportunity to be cared for, which includes, again, the entire multidisciplinary approach. And again, John, I can't underscore enough, that takes time, resources, and money. That's really, if you will, where it comes down to. What we have to do is to clearly continue to provide this level of care with all of these people who give of themselves freely to do this, if you will, and are privileged to be able to do it. But at some point in time, we do need the support, if you will, of not only the organization, but I think clearly the foundation in saying, what can we provide you with, which will help, if you will, not only to allow the pregnancy, shall we say, to flourish, but to enhance the patient care.
We'll get there. We are going to be part of the HOPE registry, which is the national registry that's going to happen. They finished their pilot phase and they'll be starting rolling out sites. We should be their third or fourth quarter of this year. And hopefully between now and then, we'll start at least looking at small pieces of that through the Women's Heart Science Center as well this year. So that's part of it. Other questions?
And I also have to kind of, if you will, shout out for Christina. I know you all know Christina. She has been an absolute, if you will, resource for all of us in terms of our, if you will, cardiopregnancy program. Not only, if you will, as part of our clinic, if you will, service, but in terms of, making sure that the patient, if you will, data and everything is kept up to date. So, Christina, we cannot thank you enough. For all that you've done for us.
Do you have a question?
I was just going to add in terms of follow-up to John's comments. I think the follow-up piece is really big. So when people are discharging, when I'm looking at things, it's not always people with the cardiopregnancy program that are seeing patients, and we're working on improving, making sure patients have appointments, but really stressing the importance of follow-up. and then also follow-up for the hypertensive patients and the preeclampsia patients. And I think those are probably the ones that have the biggest issues in terms of not getting appropriate follow-up, but at high risk for complications.
And I think that's the resource issue too, as you all know about clinic follow-ups. But as a cardio-pregnancy program and cardio-OB grows, a big drive is to see these women with adverse pregnancy outcomes back within that first 1 to 2 weeks, not just by maternal fetal medicine, although we've been utilizing their clinic quite nicely, thank you, with them texting and calling me for any questions, whether I'm in Mexico or not. But we need to start utilizing physicians, and any cardio-OB program has to evolve into taking care of these women with severe gestational hypertension and preeclampsia as well.
And-
Again, later in life, they have heart disease and they need surveillance.
You know, one of the other things I think, and I can underscore, and I think Carol can certainly speak to this, there has been a tremendous trepidation, I think, throughout the ages about valvular, if you will, either replacement, repair, or active intervention during pregnancy. And I do think that a part of this cardio-pregnancy program clearly entails discussions of which I think 10 years ago, Carol would say, I don't want to touch this woman, if you will, or any of our valvular issues. But clearly now we see there is success. We clearly have evidence, if you will, based methodology. And obviously, one of, particularly in this geography that we see, is the issue related to illicit drug use and infective endocarditis. And this is not a small problem, if you will, within the Minneapolis area anymore. It's probably the #1 issue we see now with, if you will, infective endocarditis is IV methamphetamine use, if you will, and illicit IV drug abuse. And again, people didn't think it would ever become an issue here, but it is a major issue. So I do think, again, this concept of, you know, what can we do early, middle, and late in pregnancy in terms of valvular heart disease, I think is very important.